Philip Bonomi. I'm the Alice Perry Wirtz Professor of Medicine at Rush University Medical Center in Chicago, Illinois. This is a tumor that has a relatively high cure rate if the tumor is limited to the superior sulcus and has not spread to the mediastinal lymph nodes. And if that's the case, then treatment with cisplatin, etoposide, and concurrent radiation followed by surgery offers close to a 50% chance of cure. So this is the standard therapy. There are no randomized studies because it's a fairly small subset of lung cancer patients who have this particular type of location and stage. But it's one that it can be hard to diagnose too, because many times people are seeing their physician for shoulder pain and they're being considered for various arthritic conditions when in fact it's really a lung cancer that's affecting the brachial plexus and causing that pain. So the key thing is to make the diagnosis early before it has spread to mediastinal lymph nodes or other sites. Most people do not do surgery on those patients because even in the past that's not been a good outcome. So we ordinarily treat them with concurrent chemotherapy and radiation, the same chemotherapy and radiation that we use for patients who are going to go to surgery, but we usually do not go to surgery in that group of patients. Well, I think the future direction for all tumors that are treated with radiation and chemo, locally advanced lung cancers, is immunotherapy. You know, we have a recent trial called the Pacific trial, which showed a dramatic reduction in the recurrence rate of the disease. And granted, it was a rather limited time period, but with the treatment with durvalumab, which is an immune checkpoint inhibitor, an anti-PD-L1 immune checkpoint inhibitor, the risk of recurrence was reduced by a little more than 50%. Now, again, we need more time, see what the overall survival is, but these results are very encouraging, and as far as I'm concerned, if this is approved and we would be able to use it in patients, I would start to use it based just on the results with progression-free survival. That's pretty easy. I've been doing this for over 40 years, and when I started doing it, virtually nobody wanted to be a lung cancer oncologist. In fact, we didn't really think of ourselves as thoracic or lung cancer oncologists, but I focused on lung cancer, and the number of people, at least in the United States, who are serious about doing research, either clinical or basic research in lung cancer at that time was very, very small. And now we have so many brilliant investigators that have, they started out, to me, they were very young. Many of them are at this meeting. They were rising stars. Now they're stars. And we see many other young investigators now from around the world who are rising stars. And to me, that's very gratifying because doctors really didn't want to do this. In fact, colleagues used to say, how could you be a lung cancer oncologist? How could you possibly do it? Well, I felt that it was a huge challenge, and these people needed somebody to help them. And that's the way my other colleagues who went in this area, we all felt the same way. It was a challenge, and we felt these people needed someone to help them, and we wanted to do the best we could. And certainly in the beginning few decades, we really didn't make much success. But one of the things in my career that was very gratifying to me at Rush University, we have a very collegial atmosphere there, and surgeons and radiation therapists and medical oncologists got together for patients with locally advanced lung cancer, including those with superior sulcus. And we said, well, what should we do? And we said, well, let's try using radiation and chemo together, and then let's also take them to surgery afterwards. And we made every group had to make a concession, a compromise. The surgeons had to wait until the radiation and chemo were done. That was longer. The standard therapy for superior sulcus at that time was radiate and then go to surgery right after that. Well, it took about 3 months to do our program with radiation and chemo. The radiation doctors were willing to compromise and say, well, we were concerned if you gave the medical oncologist, if we gave radiation continuously with chemo, it would be too toxic. So we asked them to consider doing intermittent radiation therapy, or we call split course, which in fact is something that most radiation therapists would say that's bad, because if you give the rest periods between radiation treatments, the tumor will start to grow, and it's going to be a problem. We won't be able to control the cancer. Our radiation therapists were willing to say, okay, we're giving it with chemo, we're willing to try it. Radiation therapist said, well, you know, what chemo are you going to use? And we said, well, cisplatin. Okay, that was fine. Everybody agreed on that. And some of the other things we wanted to do, they were concerned to be too toxic with the radiation. So we used the drug 5-FU, which by itself is not very effective in lung cancer, but it is a radiation enhancer. So our first studies were cisplatin, 5-FU, and radiation, and then not too long after that we added the drug etoposide, which is currently the standard treatment we mentioned earlier in this interview. Cisplatin and etoposide is the standard treatment, not only for superior sulcus tumors, it's also for stage 3A and stage 3B lung cancers that are in those stages because of mediastinal lymph node involvement. So that regimen, Rush was the first university to really use cisplatin and etoposide. Also, we had 5-FU in there with radiation. We did it with split course. Some of the patients who were candidates for surgery went to surgery. So that was very exciting for me, and we would see really dramatic responses in many of these patients. And of those who went to surgery, 18% didn't have any cancer left in the specimen. So that was very exciting, and those patients were the ones that did the best. With superior sulcus tumors, about half of them have no tumor left in the specimen, and that's the group generally who's going to have long-term survival. So it was exciting to be involved in that, but that was one of the few kind of high points. After that, there were a lot of not much progress made with new types of chemo, and the really exciting times in lung cancer started with the discovery of the EGFR mutation, EGFR inhibitors, now immunotherapy, and I think adding immunotherapy to the chemo, that thing I mentioned earlier, Pacific, I believe that's going to be the next area of progress for patients with superior sulcus tumors and stage 3s in general, stage 3A and stage 3B.